Good evening, class. We're going to spend well, it's going to be more than a few minutes tonight. Chapter 10, where it talks about market failures and the role of government, has a lot of information in that chapter. And some of these videos may be a little longer, maybe a little more involved than some we've had in the past. But uh, before we jump into chapter 10 and start talking about market failures, I want to go back and start bringing some information forward, make sure we don't lose sight of it as we move along our way in chapter 10. We talked about the market for healthcare professionals. We've talked about physicians and the lag time, and when you're looking at supply and demand, and it's difficult to forecast the actual supply of physicians that keeps up with demand because demand is ever changing in healthcare. And again, there's this long lag. We're talking about individuals with a 4-year degree, and then they go to medical school, and then they go to internship and residency, and they may get a fellowship somewhere if they're talking about especially cardiology, neurology, uh, some of those types of specialties. So it is a long tail from the time somebody starts as an undergraduate until they are, I want to say, turned loose, until they graduate and are ready to move forward into the world and become a practicing physician. And then we talked about the market for nurses. Market for nurses, again, somewhat difficult to forecast the need, again, because of demand changing, and also on the supply of nurses. Nurses tend to move in and out of the market more frequently than physicians do. Nurses probably have a lot more options than physicians do. Uh, they can join a union. They are serve as physician extenders to certain medical groups. They can work in hospitals. They can work in. There's a huge demand for nurses in on the health plan side or on the payer side of that financial coin, and there's also becoming more and more, um, I guess, favorable for nurses to work for staffing agencies. They have more flexible schedules. They can work per diem shifts, and you see a lot of nurses moving in that direction. And then we talked about technology, and while technology has certainly been driving the healthcare market over the last few years, there's always that concern about who's going to pay for technology. The argument is that robotic surgeries. I remember when laparoscopic procedures came into play. Um, the driver on those types of technological procedures or technological advances was that it improved the quality of care. You're probably going to have the same thing when AI gets involved in healthcare. Again, who's going to pay for it? And then one thing that if it's not paid for, and if there's not enough profit margin for entrepreneurs to develop these new innovations in technology for healthcare, it's going to slow the distribution of technology across the healthcare landscape. And I always want everybody to remember that it was Schumpeter that coined the phrase creative destruction. And his rationale, Austrian economist, and his rationale was that it's kind of like out with the old, in with the new. And as you continue to improve on innovation, you're getting rid of the old, so you're destroying the old and you're replacing it with the new, which, at least in theory, should be a significant improvement over the old. And then last week, I guess it was, we talked about the competitive market and kind of the four main things about a competitive market. There are multiple buyers and sellers. There are complete information, not only about market and supply and demand, but about pricings. There is a homogeneous product that is produced, and it's easy entry and easy access, either into the market or out of the market. And as we talked last week, there may be a few, markets or a few firms, that are, perfectly competitive markets, but they're probably few and far between. And healthcare, like a lot of markets, is uh, not involved really in perfect competition. If you go back and think about it, yes, there are a lot of buyers and sellers. Um, just look at the landscape in Nashville. I don't know what the population is uh, in suburban Nashville, but um, there's a huge number of individuals on the buyer side, and there's a huge number of physicians and hospitals and ancillary services in that Nashville market. So a lot of buyers and sellers, so we can kind of tick mark that one off. Um, Perfect information on both the consumer and the producer. I don't think we can tick that one because in healthcare it's notorious for asymmetric information, and we've talked about that, in an earlier chapter. So I'm not sure we tick that one off. Homogeneous product, maybe. Um, Most consumers and most payers, if they are buying quote office visits from a physician's group, because quality is so difficult to measure, um, they're pretty much viewing an office visit as a homogeneous product. So it doesn't matter which doctor you go to, an office visit's an office visit. And then lastly, easy entry and easy access. Yeah, I'm not sure we can tick mark that one off either. Uh, Probably somewhat easier to exit the market than it is to enter it, again, because of that long lag time on physicians. But uh, the fact that once a physician sets up a practice, they've got probably a lease on the office. They've got, long-term contracts with, consumable suppliers. Um, Probably get rid of their office staff pretty easy, but a lot uh, of the fixed cost in that practice, it's hard to consolidate those, pay them off, and get out of the market. So I'm not sure we can, tick mark that one. So at the end of the day, at least from my perspective, on a competitive market or pure competition, we might be able to tick mark, many buyers and sellers. We might be able to tick mark homogeneous product, but the other two, I'm not sure we can do. And also remember, on a competitive market, they face a market demand curve um, that is flat. It's horizontal, and price is equal to and the price is actually set equal to the marginal cost. So on a competitive market, and I've always, in a lot of these situations, I like to use corn as an example. Um, so if I have a bushel of corn and you have a bushel of corn and your neighbor has a bushel of corn, corn's corn, wheat's wheat, soybeans are soybeans. And that's what drives a competitive market, homogeneous product. None of us have a jack and the beanstalk kind of corn. So whatever the spot price is of corn, that's what we're going to sell it for. And if you think about healthcare, it's somewhat similar in a way. Office visit's an office visit. Blue Cross Blue Shield of Tennessee, United, Aetna, Cigna, whomever the payers are in the Nashville market are negotiating rates for those office visits. And while it's not necessarily set by supply and demand, it is somewhat set by supply and demand because on the payer side, especially on the health plan side, before you can offer a benefit package, you have to justify that you have a network built and you have a certain network adequacy report that you have to fill. And so there's going to be certain provider specialties that the impact of supply and demand is going to impact that price that the health plan negotiates. And with that kind of brings us up to speed. And tonight, we're going to talk about, at least in the first section, we're going to talk about Pareto efficiency. And Dolores defines Pareto efficiency, and it says, she comes right out and says healthcare markets rarely achieve Pareto efficiency. And it's, basically the definition is economically efficient outcome in society in which is it impossible to improve the situation of one individual without hurting someone else. No ability to improve the situation of everyone. And if you think about, just go back to getting in to see a primary care doc. If it's not a Pareto efficient situation, because for let's say Tennessee Blue to improve access, they may be hurting someone else. So to improve access for me, they may be hurting access for someone else. So that's why healthcare markets rarely achieve Pareto efficiency. And the first fundamental theorem of welfare economics maintains a competitive market is crucial. Otherwise, distortions in process, quantities, and social efficiency. And again, healthcare, we're probably going to view it as kind of a hybrid version of a competitive market, but it is not a pure competitive market. So the fundamental theorem of welfare economics is somewhat distorted because healthcare is somewhat of a hybrid competitive market. And then Dewars, in her text, talks about social efficiency implies that resources are optimally allocated to achieve best value. Healthcare is an intermediate step in the production of health. Because remember, medical care, healthcare, we're trying to maximize health status. And as we talked about in some of the earlier chapters, social efficiency implies that the resources are optimally allocated. And go back to, and I think we've talked about it in this class, but go back to your micro classes. At a situation where marginal benefit equals marginal cost, or in the terms of on the provider side of the financial coin, where marginal revenue equals marginal cost, three things happen: maximizes net benefits, maximizes profits, and maximizes social efficiency. And there is no guarantee in healthcare that providers are producing at a level where marginal benefit equals marginal cost. And in that respect, there is going to be some discord, let's say, when it comes to social efficiency. Market failures imply that Pareto efficiency is not achieved. So when Pareto efficiency is not achieved, at that point, there is considered market failure. And that's when Uncle Sam, and maybe not just the federal government, but maybe state governments or maybe your local governments, decide they want to play in the sandbox because they think they can do a better job of social efficiency and the allocation of those resources than the market can, than the market, driven by supply and demand. I'm not sure the government's ever able to improve a situation, but they certainly like to dabble in the situation. And then when we talk about Pareto efficiency, make sure I've got, when we talk about Pareto efficiency, they get into, in the text, they get into externalities, the spillover effect from consumption, production of goods and services not borne by a consumer and producer. Spillover effects to society can be positive if it's an external benefit, or it can be negative if it's an external cost. And then Dewar goes down and she goes through some mathematical formulas and gives us some acronyms. Healthcare markets will not achieve Pareto efficiency if there are externalities. So when externalities are involved, we're not going to hit Pareto efficiency. And then she defines society marginal cost equals private marginal cost. That's a marginal external cost. She defines it as MEC, or the acronym. And then marginal benefit to society equals the private marginal benefit to society, and we end up with a marginal external benefit. So I think where Dewar's trying to go is she wants the market to be Pareto efficient if the marginal benefit to society equals the marginal cost to society. External cost of production, and then she goes through and talks about the external benefits of production and external cost of consumption, external benefits of consumption. So she goes through all of the calculations, But at the end of the day, a healthcare market is just not going to reach Pareto efficiency. And that is why you have um, state, federal, local governments wanting to play in the market for healthcare goods and services. Medicaid, Medicare, um, VA and TRICARE are both they're Department of Defense and Veterans Administration, but the government has decided that they need to help. Sometimes they call it the disenfranchised population, but you will see a lot of government interaction within that socially kind of disenfranchised. And I think it's in Nashville. Can't remember the name of the clinic, but down at the corner of Jefferson Street and 14th, I think, there is what appears to be a community clinic there. So pretty close to Fisk campus. Meharry, in the medical clinics at Meharry, I'm sure I don't know for sure, but I would be really surprised to help treat a kind of an indigent population that they aren't receiving some federal and state grants to help improve access to an indigent population. My wife and our family lived in San Diego for years, and Mercy Hospital in San Diego was the hospital that saw most of the Medicaid kind of indigent population. It was part of their mission and part of their vision to serve that population. So you would, and I don't know if there is a Catholic Health Hospital in Nashville or not. St. Thomas, maybe St. Thomas, I'm not sure. But you will see those hospitals that will take care or provide those goods and services to individuals that may not be able to afford health insurance, may not be able to qualify for Medicaid, maybe older population that can't qualify for Medicare, an older population. Some of the individuals in an older population, it's called a dual eligible, where they qualify for both Medicaid and they qualify for Medicare to help with not only living expenses but on the healthcare side. So a lot of opportunities for the government to, I guess, provide assistance, let's say, in the national market, just like it's here in the Atlanta market. The government's playing in healthcare here in the Atlanta market and in most markets around the United States. The government is dabbling in the healthcare market to some extent. And with that, it brings us to the kind of the discussion of public goods. And public goods can be jointly consumed by everyone. If you think about it, public goods are typically national parks, maybe state parks, goods that are provided and they can be consumed by everyone. They're also, and what determines a public good, it's a non-rival good, and it has non-excludability. It's basically a non-payment. You can't exclude people for payment. In other words, you can't charge people to use a public good. You get into a lot of issues with like free riders on a public good because they're going to use it and they're not going to pay anything for it. And these goods typically are not provided by the private sector. Maybe to some extent, the private sector will provide some of these goods, but it's usually as a subcontractor to a government agency. But it's as far as a private company moving in to decide, hey, we're gonna provide this public good, on our own dime. There's not enough profit margin there, so it's more than likely just not going to happen. So if you see a private company, offering what is considered a public good, it's usually because they are subcontracted out to some kind of a government agency. And public goods provided via government and individuals are compelled to pay for them via taxation. And there's where we go back to the example I just provided, that what appears to be a health clinic at the corner of Jefferson Street, and again, I think it's 14th. Kind of a health clinic, a community clinic that's being paid for by, taxpayer dollars. Could be paid for by, taxpayer dollars in the, in the state of Tennessee, or it could be subsidized by federal funds. My guess is a lot of, taxpayer dollars are subsidizing some of the clinics at Meharry. Matter of fact, they're probably subsidizing a lot of the clinics scattered all at a lot of the hospitals around Nashville. And that's where we get into public goods versus publicly provided goods. And you typically think of publicly provided goods as, again, it's, generated by tax dollars. Think about, school systems, local parks, street lights, sidewalks, publicly provided goods, but those publicly provided goods are generated via taxation or some way through taxable dollars. And again, on a public good, at least the government thinks it hits Pareto efficiency when the society marginal benefit equals to the society marginal cost. That's why, again, government's trying to play in the sandbox, trying to get to that level of Pareto efficiency. I'm just not sure they hit that level. Healthcare is usually not public goods unless the case of public health interventions, mosquito control, restaurant inspections. Individuals don't think about restaurant inspections as being part of kind of I guess, healthcare. But it's, at least it used to be, managed by Department of Agriculture on, a lot of the health inspections. And it is kind of a health intervention, ensuring that restaurants are clean and sanitary. Mosquito control in Atlanta, mosquito control is a private sector, I guess, good or service. So if I wanted mosquito control here in Atlanta, I have to pay for it out of pocket. When we lived when I was in graduate school and we lived in Westerville, Ohio, which was the suburb of Columbus, mosquito control was provided. It was provided to the residents of Westerville, but you were paying a Westerville city tax, and that was just part of the taxable. Your taxable dollars went to provide that mosquito control. And then DeWar spends just a few minutes talking about information imperfections. And she talks about market failure due to imperfect information. And again, we've talked in several of the earlier chapters with healthcare, not only with the production of goods and services, but the consumption of goods and services. There's significant uncertainty. Healthcare, for the most part, is a random event. Asymmetric information and knowledge between the patient or the consumer and the physician, the provider. And so market failure within healthcare usually will be generated by this imperfect information. And Pareto efficiency requires certainty. What, when, how, why? And it requires certainty for not only the consumer, but certainty for the producer. If you go back to your old micro notes, and when they talk about the production decisions that a company needs to make, typically you think of what to produce, how to produce it, for whom to produce it, and then lastly, how do you keep a few dollars in reserve, whether it's retained earnings or something along those lines, for future production or future productivity. And in healthcare, we'll just take Meharry Medical Center. The CEO or the president of Meharry Medical Center, a medical college, is constantly thinking about, both in the short run and in the long run, he is thinking about what goods and services will they provide? How are they going to provide them? What's the population they're going to provide them for? And he's always or she's always concerned about holding back some dollars for future productivity. And it's going to be the same, you know, whether you're Meharry or whether you're at Vanderbilt or St. Thomas, or I think there's a TRICARE medical center I've seen, or whether you're at a provider's office, you're going through these we'll call them, mental gyrations, but you're going through these decision trees and these decision processes as a producer of healthcare goods and services. You're going to continue to ask what, how, for whom, and how do I keep some back for reserves? Markets can't accurately determine supply and demand, and they're unable to equate marginal benefit to marginal cost. And that's private marginal benefit to private marginal cost. And you can't it's really difficult to determine supply and demand because of the randomness of healthcare goods and services. And then she kind of winds this information imperfections up by saying uncertainty as to illness, health status, deterioration or health status, and healthcare knowledge. And it is uncertainty across all of the kind of the production process that's involved with maintaining your health status. You've got more than likely a lack of healthcare knowledge, especially on the consumer side. You've got the randomness of illness. You've got the health status that not only we're born with, but the health status that we continue to manage as we go through life. And there is a certain level of deterioration of health status as we all get older. And then lastly, she makes a very valid point when she says the wrong decision in healthcare is sometimes more detrimental than no decision. And that is a true statement if there ever was a true statement, because the wrong decision by your healthcare provider can definitely lead to a negative outcome, which in most cases, a negative outcome is worse than no decision at all. And I think with that, we're going to stop there. And when we come back, we're going to talk a few minutes about the monopoly model. Talk to everybody in a few minutes.